Hey everyone, welcome back to the emDOCs.net videocast. Today, we're covering acute brain injury, specifically hypotension, antibiotics in invasive mechanically ventilated patients, transfusion targets, and then finally, ventilator management. We all know that the primary treatment strategy in patients with severe brain injury is to optimize the cerebral perfusion pressure, potentially lower the ICP, and then avoid any physiologic derangements like hypotension, hypoxemia, and hypoglycemia. But what is the impact of something like hypotension on these patients? That brings us to our first paper, Hypotension and Adverse Outcomes in Moderate to Severe Traumatic Brain Injury, a systematic review and meta-analysis published in JAMA Network Open 2024. Authors included studies evaluating patients 10 years and older with moderate to severe TBI. Authors sought to evaluate the incidence of hypotension in these patients and its impact on mortality. They included 51 studies with over 380,000 patients. Overall, they found an incidence of hypotension of 18%. The mortality-adjusted odds ratio was 2.22, which was statistically significant. The biggest takeaway from this study is that hypotension in TBI is bad. Unfortunately, the authors don't provide specific treatment recommendations or even numbers to shoot for. What you see is what you get. Let's say you have to intubate a patient with severe brain injury who's decompensating. You perform a flawless neuroprotective intubation, but once you've intubated the patient, our job is not done. And something we often don't think about is the rate of ventilator-associated pneumonia. This is a nosocomial infection that occurs several days after the patient has been intubated and they're on the ventilator. The overall incidence is anywhere between 5 to 40%, but in patients with acute brain injury, that number can reach upwards of 60%. And that brings us to our next paper, ceftriaxone to prevent early ventilator-associated pneumonia in patients with acute brain injury, a multicenter, randomized, double-blind, placebo-controlled assessor-masked superiority trial published in Lancet Respiratory Medicine, May 2024. The primary question was in adults with severe brain injury who require invasive mechanical ventilation, does an early single dose of ceftriaxone compared with placebo reduce rates of early VAP? This was a multicenter, double-blind, placebo-controlled RCT completed at 8 hospitals, 9 ICUs in France. Authors included adults with a GCS of 12 or less, intubated for 12 or less hours, and an expected mechanical ventilation duration of at least 48 hours. Authors randomized patients to either ceftriaxone 2 grams at intubation versus placebo. The primary outcome was early VAP based on the ATS or American Thoracic Society criteria. They had a bunch of different secondary outcomes determined at ICU discharge, day 28, and also day 60. Let's get to the results. Authors included 319 patients. 162 were randomized to ceftriaxone versus 157 in the placebo group. The primary outcome of early VAP occurred in 14% of the ceftriaxone group versus 32% of placebo patients. This was statistically significant with an 18% absolute difference. For secondary outcomes at day 28, authors found lower VAP risk, fewer median ventilator days, improved modified Rankin score, and lower mortality. At day 60, they found more median ICU and hospital-free days, but there was no difference in neurologic outcomes and no difference in mortality. This study was well designed. They used intention to treat analysis, and it was double-blinded. Overall, the groups were well balanced. They used a standardized VAP definition based on ATS criteria, and they used standardized VAP prevention measures like oral care, tracheal suctioning, head-to-bed elevation, early weaning, but those measures, they weren't monitored during the trial. The primary outcome is also a bit controversial because the diagnosis of VAP is notoriously inaccurate. Finally is generalizability. This study was completed in the ICU in a single country. But based on the results of this study, a single dose of ceftriaxone likely reduces VAP in intubated patients with severe brain injury. Personally, this changes my practice. I'm administering a dose of ceftriaxone for intubated patients with acute brain injury. What about hemoglobin transfusion thresholds? Well, most guidelines recommend using a transfusion threshold between 7 to 8 grams per deciliter. It is a bit higher for patients with other conditions like cardiac issues, but these guidelines, for the most part, are based on fairly high quality data. Unfortunately, many of the included studies in these guidelines did not include a significant proportion of patients with brain injury. That brings us to our next paper, Restrictive versus Liberal Transfusion Strategy in Patients with Acute Brain Injury, the TRAIN Randomized Clinical Trial, published in JAMA 2024. The primary question was, in patients with acute brain injury and anemia, does a liberal transfusion strategy compared to a restrictive strategy improve neurologic outcomes at 180 days? This was a multi-center, parallel group, open-label RCT completed in 22 countries, 72 ICUs. Authors included adults in the ICU with TBI, subarachnoid hemorrhage or ICH, a GCS of 13 or less, an expected ICU length of stay of at least 72 hours, a hemoglobin of 9 or less within 10 days from injury. Patients were randomized to a hemoglobin transfusion threshold of 7 versus 9. The primary outcome was unfavorable neurologic outcome at 180 days based on the Glasgow Outcome Scale Extended. For secondary outcomes, authors looked at 28-day mortality, organ failure, ICU length of stay, adverse events, and cerebral ischemia. For results, authors included 806 patients. 393 were randomized to the liberal group versus 413 in the restrictive group. Authors found unfavorable neurologic outcomes occurred in 63% of the liberal group versus 73% of the restrictive group. That was a 10% absolute difference, and this was statistically significant. Authors found no difference in 28-day mortality, organ failure, or ICU length of stay. However, they did find fewer cerebral ischemic events in the liberal transfusion group. This study asked an important question. They used an appropriate design, but there are several limitations. First, they had to adjust the sample size twice due to slow enrollment. Also, the ICU staff taking care of these patients were not blinded. We don't know if these patients received a transfusion prior to their enrollment. In fact, most patients were enrolled at hospital or ICU day 3. There was also a wide definition in brain injury types, and hemoglobin kind of serves as a surrogate marker for cerebral tissue oxygenation. The bottom line from this RCT is that in patients with acute brain injury and anemia, a hemoglobin transfusion threshold of 9 grams per deciliter may reduce unfavorable neurologic outcomes at 180 days. I would like to see more randomized data when it comes to this, but I'm not going to be surprised if guidelines start to change. This is definitely an area to pay attention to. Let's end with our bonus article, and that's lung protective mechanical ventilation in patients with severe acute brain injury, a multi-center randomized clinical trial, published in November 2024. This was a multi-center open-label trial that enrolled 190 adult patients with acute brain injury who were intubated but did not have ARDS. Patients were randomized to a lung protective ventilation strategy versus a conventional ventilation strategy. The primary outcome was a composite of death, ventilator dependency, and acute respiratory distress syndrome at day 28. They also looked at neurologic outcomes for secondary outcomes. Overall, they found that in patients with acute brain injury without ARDS, a lung protective ventilation strategy did not reduce mortality, weaning from the mechanical ventilator, or ARDS, and there was no benefit in neurologic outcomes. In fact, many of these outcomes were worse in patients receiving lung protective ventilation. In summary, we looked at hypotension and TBI, antibiotics for prevention of ventilator-associated pneumonia, transfusion targets in patients with severe TBI, and ventilator strategies in acute brain injury. Thanks for watching, and stay safe and healthy, everyone.